Welcome to the Calcium Masterclass series brought to you by Shockwave and Optima Education. Today's Class 12, is there a conventional approach to eccentric calcium? I'm Ziad Ali, a consultant cardiologist from St. Francis Hospital in New York, and I've come to London today to be with my good friends James Spratt and Jonathan Hill, and Margaret McEntegart, who has recently crossed the pond to work in New York too at Columbia University Hospital.
We'll be exploring eccentric calcium in today's live case, which is coming to us from St. George's Hospital in South London. And today's operators will be Rob Riley and Simon Wilson.
Before the practical, though, we're going to take you through some theory, with James answering the question, is there a conventional treatment option for eccentric calcium? But Margaret's going to start today's session with a talk on the calcium arc and how it is relevant to eccentric calcium. Over to you, Margaret.
Thank you, Jono. So is eccentric calcium relevant? So in order to answer this question, we need to consider two things. One, how prevalent it is in the patients that we're treating. And two, how it impacts on procedural and clinical outcomes. So if we start with the prevalence, we know that calcium in all its morphologies is more prevalent in certain patient populations. So older patients, patients with chronic kidney disease, patients with diabetes. We don't know, though, whether certain morphologies of calcium are more common in these different subgroups. In order to determine the prevalence of something, we need to have a definition for it. So while we have an angiographic definition for the severity of calcium, and we can look at these angiograms and think the one on the left maybe represents a nodule, the one in the middle with this tramline calcium, concentric calcium, and the one on the right, eccentric calcium. We don't know because we're looking at two-dimensional images with limited resolution. So in order to define what eccentric calcium is, we need to use intravascular imaging. You see two nice examples here in the OCT and the IVUS, and this has been correlated with appearances we see on histological analysis. So what is the definition of eccentric calcium? So sometimes and most commonly it's defined as less than 180 degrees of calcium, or sometimes that's described as the most eccentric calcium. Sometimes it's defined as up to 270 degrees, with everything over 270 considered concentric. So taking all that into consideration, what do we know about the prevalence of eccentric calcium? So this is data from about 30 years ago. It was all-comer target lesions, it was IVUS analysis, and they looked at how much calcium was present. And what they saw was in about 25% of these lesions there was no calcium visible in IVUS. 50% the calcium was less than 180 degrees, and about 25% it was over 180 degrees. If we then look at an enriched calcium cohort of patients, this is data from the pooled OCT analysis from Disrupt, and what they saw was about a quarter of the patients had less than 180 degrees, another quarter up to 270, about 50% had concentric calcium over 270. So in this enriched patient population, you see this curve shifted over to the right-hand side. So in all-comer lesions, it seems about 25% of patients have more than 180 degrees, while if you see angiographic severe calcium, then about 75% of the patients are likely to have more than 180 degrees of calcium. So how about the impact of eccentric calcium on procedural and clinical outcomes? So we know that if you have eccentric calcium, particularly if it's thick, if you try to use a balloon-based device to modify that calcium, the balloon is going to exert undifferential force against the vessel wall. And what will happen is once it hits up against the eccentric calcium, it'll then hyperexpand away from that to the more elastic areas of the quadrants of the vessel. If you try to use atherectomy, if you have a situation like you see here, where you get unfavourable wire bias, the burr is going to sit away from the eccentric calcium and you're not going to get the contact with the plaque that you need to cause modification. Even if you get favourable wire bias when dealing with these types of lesions, you're likely to get fairly limited debulking of the superficial calcium and leave the deeper calcium unmodified. So this is a case that I think illustrates this nicely. So this is an 83-year-old man who had a PCI to his right coronary artery for an acute coronary syndrome, and he came back for stage PCI to his LED. So what we can see angiographically is that in the proximal LED has this tramline calcium that we might assume is severe concentric calcium. And then further down the LED, we see calcium on the right-hand side of the vessel, angiographically appearing more eccentric. So we might be more concerned about that appearance proximally and be kind of inclined to be less concerned about that lesion further down the vessel. So the vessel was attempted to be pre-dilated. In fact, the mid lesion was actually more resistant to dilation with non-compliant balloon than the proximal lesion. And what you can see here in the IVUS is that there's this thick eccentric calcium in the mid LED. And we see that there's kind of complete attenuation of the signal behind the calcium, suggesting that it's most likely to be thick. So during this case, the first strategy that was elected to be used was an atherectomy of the 1.5 burr. Okay, so here's a case that's a really nice example of this type of situations. This is an 83-year-old man who originally presented with an ACS and had PCI to his right coronary artery, and he's come back for PCI to his LED. So we can see in the angiogram that in the proximal LED, there's tramline calcium, which we might suspect to be concentric. In the mid-LED, there's more calcium on the right-hand side of the vessel, and we might describe this as being angiographically suspicious of eccentric calcium. So the lesion was attempted to be dilated with a non-compliant balloon, and we could see the balloon was inadequately expanded. So we went on to perform an IVUS, and what you see in this IVUS run here is from about 7 until 1 o'clock, there's a very eccentric plate of calcium, which in certain segments is very attenuated, suggesting it's probably thick calcium in that segment. So initially the decision was made to proceed and treat this long segment of calcific disease with atherectomy, and a 1.5mm burr was used, which actually crossed, as you might anticipate, fairly easily, suggesting probably we weren't going to get adequate modification. And when we repeated the IVUS, we could see that that eccentric plate of calcium was completely unmodified. And actually, when in the longer pullback in the proximal vessel, we had actually created some modification of the concentric calcium, but absolutely no modification of that eccentric plate further down. And then you see again here, there's this residual wasting on the balloon expansion, and you see that the balloon is expanding away from the plate of calcium. You see the wire within the balloon is hugging the calcium, the balloon's expanding away from the calcium. So we decided that this required further modification, and we took an IVL balloon, delivered 40 pulses, and then took a 3.5 non-compliant balloon, and then further 4 non-compliant balloons to the more proximal vessel, sizing this according to the IVUS, and then the vessel was stented and post-dilated. And as you see, we got a fantastic angiographic result with great expansion in both the areas of eccentricity and concentricity. So here was the final IVUS run, and this confirmed that we had optimal and symmetrical stent expansion and very reassuring MSAs throughout this long segment of calcific disease. So in conclusion, eccentric calcium is common and it impacts both our procedural and our longer-term clinical outcomes. Dilation with balloon-based devices is usually ineffective due to differential expansion away from the calcium towards the elastic tissue. Calcium-specific therapy should be considered to treat eccentric calcium, especially when it's thick. In contrast to the limitations of other balloon and atherectomy devices, IVL provides more predictable and selective treatment of these types of eccentric calcified lesions.
Thanks so much, Margaret. That was an excellent presentation highlighting some of the myths and some of the truths that we need to learn more about eccentric calcification. So in your clinical practice, how do you approach isolated eccentric calcific disease?
Great question, Ziad. So the first thing I'll always do is early in the case as possible is image and really define the calcium in all the ways that we can to try and get a sense of how much it's going to impede my stent result. So I'm going to look at the arc, I'm going to try and look at the thickness and get a sense in the length of the calcium and get a sense of whether I think I'm going to need the calcium-specific device to modify it. And then usually, if the arc is less than 180 and it's not particularly thick, I'll usually take a 1-to-1 non-compliant balloon and see if it expands, re-image and check whether I feel that I've created any kind of modification to that. If there is an eccentric plate of calcium that's thick, then I'm going to have a lower threshold to take a calcium-specific device. And I think that, I think one of the great things about IVL becoming available is I think it's made us all much more attentive to how different morphologies of calcium respond to different treatments. And I think that our knowledge in terms of how, for instance, atherectomy can affect these types of lesions has really developed. And we can use the imaging in that type of situation to see if the imaging catheter is going to hug the calcium and hopefully push that type of device towards the calcium. And also assess whether it's not going to modify the calcium, because it's very frustrating if you take out an atherectomy device for an eccentric lesion and it just spins right past it and doesn't modify it at all. If I've got an eccentric plate and it's very thick, I'm probably going to go straight to IVL, because even if I do impact the calcium with atherectomy, I'm only going to impact the superficial luminal calcium, and I want to try and affect the deeper calcium, both to improve compliance in the vessel, but also to try and get better stent expansion. So that's really the kind of thought process I go through in the cases when I encounter them.
So let me ask the panel an important question. We have pretty historical data that shows asymmetry and eccentricity in stent expansion doesn't impact clinical outcomes. Then we have very strong biovascular scaffold data which shows that eccentricity and asymmetry strongly impacted clinical outcomes. This has never been studied specifically in the context of calcium. What's the impact of that? Have we grabbed onto older data that doesn't really fit our current clinical context, which is obviously you can see I'm biased towards, but what are your thoughts on this topic, and do we need to study it more?
I think it's one of the dangers of overemphasizing isolated data that aren't representative of necessarily where we are today. And this is a good example. We're talking about eccentric calcium, we're talking about calcium morphologies. All this is new to the table in interventional cardiology. These patients weren't considered for percutaneous revascularization not so long ago. So we can extrapolate data from younger patients in whom, softer plaques and all the rest of it, probably more tolerant of events, all these kinds of issues. So it's almost like a clean slate. Let's understand now what really does matter. This comes back to the threshold of treatment effect for eccentric calcium. What is the treatment effect? When can you ignore it? When do you have to treat it? But for me, the strong message is if you have to treat it, at the moment, there's really only one way to selectively target it.
Yeah.
I think the question is going to be answered from the imaging study, Illumian 4, I think hopefully later this year. So the optimal PCI study, big subsection of those cases were heavily calcified vessels with all the modalities available. There was intravascular lithotripsy, rotational atherectomy. I think even orbital was included. So I think the imaging data from the calcified lesion population in Illumian 4 may answer this question.
How do you use your pulse management strategy in the context of eccentric calcium that's in the presence of other more classic modalities that require modification? You have a nodule proximally, you have a long segment of eccentric, then you have concentric. We have 80, they have 120.
Yeah.
So how do you manage your pulses?
Yeah, I think that's a great question. And to be completely honest, I don't think we really completely know how best to distribute the pulses. I would be inclined to, if I had a situation like that where I have 3 lesions, all of which are severe, but different morphologies, I would probably start off by thinking I'm probably going to divide my pulse therapy between the 3 areas. Now, obviously, there's some data to suggest you need more or less in different types of morphology, but I have to say that I think we're still not absolutely certain about how we should distribute that in that type of situation. So I think that's somewhere where we need more data to try and determine in which of these lesions, or a combination of those types of morphologies, where we should treat it. And I think you can gain some knowledge up front. So I think if you've taken an NC balloon before you take your IVL, that'll give you some information. And also, if you've used one device and delivered all your therapy, and then you re-image, and you feel you're not quite ready to proceed, you're going to have some sense from the first therapy. But I think until we have more data, I'm not sure I absolutely know how I should be doing.
The inverse of that question is, which is most impactful?
Yeah.
Eccentric, concentric,
Yeah.
or nodular calcium? And actually, it's the opposite answer than we thought it was.
Yeah.
It's
You're
not
right.
concentric.
Yeah.
It's not concentric.
We're
good at that.
We're good at that. We know how to.
Yeah.
We know how to identify it. We know how to treat it. We know it's safe. It's the nodules and eccentric where all the unanswered
Yeah.
questions are.
Yeah, yeah.
But I think,
think-
the principle, though, is that the higher the calcium volume, irrespective of the
Yeah.
distribution, the more shocks you'd need to apply to modify that volume of calcium.
Yeah.
So the bigger the volume, whether it's thicker or more concentric, you need more shocks.
I just want to highlight something you said, Ziad, that I think is a great tip for people. So often you see people take the device and they sit it across a lesion and just pulse, 80 shocks in the same spot, because it's a short lesion. So that idea of getting people to just move the device a little bit, back and forward, I think is a great tip for improving the efficacy.
And quite easy for those with short attention spans who feel we've got to be doing something anyway.
So Margaret, you were one of the few people who's worked on both sides of the Atlantic.
Yeah.
So you were involved in the early stages of
Yeah.
shockwave in Europe.
Yeah.
And so what you learned in that early situation with all of your experience with calcium modification,
Yeah.
was it a different learning process for your colleagues in the US? Were you able to modify or accelerate the learning?
That's
for
a
your
good
colleagues
question,
there?
John. I think what I suppose really struck me is when we first got the device, and obviously we did cases together, me, you and James, initially we were using it pretty much dedicated in concentric calcium. It's very interesting how when I arrived in New York, everybody's using it in all morphologies of calcium.
Mm-hmm.
So the evolution of the application of the device in that time span is really changed, I think. So I haven't heard anybody there say, I'm taking it out because I see concentric calcium. People are taking it out because they see calcium, they think it's going to be effective, or they feel it's a good choice in the patient subset they're treating. So I think that's a big change. I think in the US, because there's been this experience upstream in the UK and Europe, people have got their head around the fact that the device is suitable in all morphologies and useful in all morphologies.
I think that's because it rapidly became useful in left main stem disease.
Yeah.
And obviously that was excluded from the disrupt, unprotected left main were excluded from the disrupt series of studies. And I think we do have some data coming. James is the PI for the left main study, which obviously includes all morphologies of calcium.
Yeah.
So I think we gained a rapid understanding because we all wanted to use it for left main. It became the logical, when we went to a real world population.
Yeah, and I think to be honest, the pooled OCT analysis from Disrupt has been incredibly informative around that. I think, and people seem to really have kind of embraced that data and very quickly, put it into clinical practice.
And credit to Shockwave in that regard, because we have data from over 2,200 patients with individual patient data. There's registries all around the world, and they're investing into answering unanswered questions. And to be honest, the R&D is also moving forward in making sure that the unanswered technical limitations that exist with overall in calcium modification are being managed and being taken seriously to optimize patient results.
And this is an example of that collaboration, an educational format, which there's no restriction on what we talk about. We want to solve the problems for the patient's benefit, and I would definitely echo those sentiments of kind of positive collaboration in the right direction.
So Margaret, one of the things that we don't have is the OPN balloon that is available here. And perhaps we can discuss what roles high pressure balloons would have in situations like this where there's eccentric calcification. I can't really see how that would be further valuable to an NC balloon and would create fibrocalcific tears.
I don't know. To me, it's not a question that really needs a lot of answering. Mechanistically, it's a high pressure balloon, so you're going to higher pressure. So you're going to do what you were doing, only at higher pressure. So where is that useful? Well, I mean, it's useful in concentric calcium, and that's probably safe. You can apply circumferential force. But in the eccentric calcium, it'll do the same thing that your NC balloon was doing, only it'll do it at higher pressure. So if it's going to drive the calcium at the wall of the artery, it'll do that more efficiently. So I don't see a role in eccentric calcium. I don't really see a role in nodular calcium as well, because, I mean, if an NC is not going to do it, because there's no underlying soft tissue, whether that's lipid or whether it's hematoma, then you need selective modification, a bit like we'll discuss in one of the upcoming webinars. But I don't understand how greater force application is going to solve the problem.
I think that what Shockwave has shown is that if you can achieve expansion, so you can get that your MSA at low pressure, that is the key safety advantage. And we've seen this all the time with cases where IVL has been used for the initial expansion, and then we've stuck to our kind of old habits of using high pressure NC balloons to finish off cases. That's where the complications have arisen. And I think it's the same with OPNs, as James says. It's just we'll do it even more effectively in creating perforations and more barotrauma.
So let me ask the panel a final question before we move on, and that is, if there was no cost implications, would you use IVL in every single calcified lesion?
Yes. If I could cross it, I would shock it.
I don't like every and always, because
More often than not, shall we say that?
yeah, for sure, more often than not. I think its weakness is currently its crossable profile, particularly in critical lesions. It's still not ready to compete with rotational atherectomy there. That aside, it's not even that controversial a question. I know it's a shockwave webinar, but it's actually so far ahead of the competition in terms of modifying calcium, and the mechanism of action is so different from the normal traumatic measure that I don't think it's that difficult a question. So, yeah.
So if you had a crossing device, and you could use a device to cross the lesion, if you can cross it then, and you can deliver a shockwave balloon, then I think it's suitable for every lesion.
Margaret, final words on this topic?
I think we've got to a place with complex PCI where we can pretty much treat everything, and our focus now should be on safety, and I think this is the safest device.
So now we're armed with that background on eccentric calcium and the calcium arc. It's over to James to tell us if there's a conventional treatment option for eccentric calcium. James.
Thank you, Jonathan. So my talk today is there a conventional treatment option for eccentric calcium? We've heard that how eccentric calcium is common. Let's remind ourselves why it's important. Here you have an IVUS and an OCT representation of a 180-degree arc as seen by the schematic. And what the schematic is planning to capture here is the hidden bit behind where the dropout is in the imaging. And that's what makes it so difficult. You can see, as Margaret has illustrated earlier, that according to this OCT core lab analysis, about 50% were eccentric calcium. So why does it matter? Well, the first question is, eccentric calcium is relevant if it limits mean stent area. Doesn't seem to be stent concentricity. On this schematic, consider that if the calcium is unmodified, the only area the stent can occupy is by expanding the adventitia to the right. You can see that the lumen is constricted. It's only 2.4 millimeters squared. The vessel diameter should be up to as big as 12 millimeters plus squared. And if we don't modify the calcium, that has to be occupied to the right of the calcium. So if we fail to appreciate the impact of eccentric calcium and we attempt to maximize the area post-stent implantation, this may lead to complications which may have a significant adverse effect on patient outcomes. So the question we're really asking is, what is the threshold of treatment? If the arc of calcium is sufficiently limited, this can be achieved without disruption of calcium. Put the stent in, no problem. If the arc of calcium is thin enough, then the calcium may fracture with non-selective treatment. Again, put the stent in, no problem. So what we're asking is, how can you safely achieve optimal MSA? And we can think of MSA as luminal reserve. It's the area you want the stent to get to so that subsequent neoatherosclerosis or neointima can ingrow and still leave plenty of space for the blood to render the lesion non-physiological. And attempts have been made to understand what threshold these two criteria become relevant. OCT, we know, allows measurement of depth as well as arc and length. While none of these factors are dichotomous, the cumulative impact can be seen on the stent area. As you can see, as they add up, our MSA drops. IVUS, on the other hand, is unable to precisely measure volume. Arc and length remain relevant. So in certain patterns of eccentric calcium, we need to fracture the calcium sufficiently to restore compliance in that part of the arterial wall and to fracture the calcium into small enough bits that we can compress the calcium and allow the stent to expand. So in terms of lesion preparation, the mechanical goals are sufficient disruption of calcium to allow optimal stent expansion. And if we fail to modify severe eccentric calcium, we result in the stent area being occupied by adventitial overexpansion. And that relies on luminal gains are dependent on this overexpansion of non-calcific quadrants. So how should we manage? Well, all balloon-based therapies such as non-compliant, OPN or cutting result in concentric force or barotrauma. Balloon inflation will lead to preferential expansion away from calcific segments towards the more distensible opposite wall. And this leads to stretching and/or dissection of the healthy or non-calcific segments and a low probability of calcium modification. The degree of force applied with the balloon does not change this. This also explains why we cannot rely on balloon expansion only as a metric of lesion preparation. In fact, you can see here as this balloon expands that the wire bias is now towards the calcium. And you can see this on the angiogram actually. And this could be conceptually visualized here, where it's possible to understand how concentric calcium may be easier to fracture and easier to assess the impact of treatment. As the force is applied, you break the chain with the concentric calcium, you just push away from the chain with the eccentric calcium. To reinforce this point, the presence of significant eccentric calcium requires adventitial stretch to achieve an adequate MSA. The use of high-pressure compliant balloons increases the probability of excessive stretch and therefore risks vessel perforation. You can see this is almost the danger zone, if you like. So attempts to modify the calcium with balloon-based therapies post-stent implantation do not improve the adverse safety profile associated with adventitial stretch. Consider this example of a thick plate of eccentric calcium with relatively healthy vessel in the opposite quadrants. This was treated with an NC, then a cutting balloon, and a large dissection can be seen opposite to the lesion involving the ostium of the diagonal side branch. Note that the eccentric calcium remains unmodified. So, what options are available? Atherectomy can also be used in severe calcific disease. In contrast to balloon-based therapies, atherectomy allows for selective targeting and ablation of calcium. Critically, this effect is contact dependent and therefore sensitive to wire bias and lumen size. Therefore, in large lumens, or if the wire is biased towards the non-calcific quadrants, then the atherectomy is unlikely to be effective. And actually, this contact-dependent ablation is associated with a relatively limited degree of volume reduction, and secondary treatment is required. If the calcium is sufficiently thinned, then maybe this is balloon-based therapy alone. By contrast, by reminder, balloon-based therapies apply compressive force only, and this promotes fractures that run parallel to the applied force. The critical difference with lithotripsy is that in addition to these compressive forces, there are also tensile and shear stresses. So tensile stresses promote fractures that run perpendicular to the applied force, and shear stresses also promote fractures perpendicular to tensile forces. So you get this fracturing in multiple directions. And this crazy Pravian fracturing can be seen post-IVL in this micro-CT. Note that OCT only identifies fractures coaxial to the imaging beam. In the corresponding micro-CT and in the histology, transverse fractures in this example can clearly be seen. And this is a great histological example of just how selective IVL is for calcium. So you can see within this axial slice that there's only a very small portion of eccentric calcium here. Yet despite this highly eccentric portion, you can see microfractures at high power magnification of these histological specimens. And these aren't going to be visible by standard imaging, but they are likely to contribute to restoration of vascular compliance and optimal interventional outcomes. Frequently, however, you can see these fractures with both OCT or IVUS. And where you see these fractures, you can see that they're associated with an immediate luminal gain, and with stent implantation, you get separation of the plates even further to increase this luminal gain. So when you compare IVL to balloon-based therapies and atherectomy, this ability to modify superficial and deep calcium independent of hydrostatic force or wire bias indicates an advantage in eccentric calcium and nodular calcium, and it allows more reliable lesion modification, concentric stent expansion, and optimal mechanical outcomes. And this hypothesis is supported by pooled data across the CAD group of studies, demonstrating no difference in MSA or stent expansion irrespective of calcium angle. So the principles of calcium modification remain constant. Assess using intravascular imaging, define threshold of treatment, assess modification prior to stent implantation, and use intravascular imaging to optimize stent outcomes. So in conclusion, eccentric calcium remains an underappreciated challenge, which conventional balloon treatment fails to fully address. IVL offers a number of mechanistic advantages, and these have already translated into consistent arcs across calcium morphologies. With many thanks for your attention.
Okay, so now it's time to go over to St. George's Hospital to join Rob Riley and Simon Wilson, today's operators on an eccentric calcium case. Rob, Simon, how are you guys getting on? Are you ready for us?
We're doing well. Fantastic.
Yeah.
All right, show us what you got.
So we got Navalia is going to give you some of the background to the case, and then we've done the setup pictures, which we can share with you, and then we'll take it from there. So Navalia, over to you.
Okay, thank you. So our patient is an 85-year-old lady who presented last week with decompensated heart failure, preceded by some chest pain 5 days prior to the presentation. On admission, her troponin was 400, but that probably peaked a few days before that, and it was downtrending during her admission. She had some anterior T-wave inversion, and in terms of comorbidities, she's hypertensive, but not on any medication. Echocardiogram showed moderate LVSD with an estimated ejection fraction between 40 and 45%. She was started on aspirin and ticagrelor, and her bloods are satisfactory. And last week she had coronary angiography, which showed the following pictures. So she's got a calcified proximal RCA disease, which is severe. And her left coronary artery looks like this. A less calcified LAD lesion, which is presumably the culprit, and that was treated with a drug-eluting stent. So the plan was for her to have stage PCI to her right coronary artery as an inpatient.
Great.
All right, fantastic. So a little bit of renal dysfunction, and we wanted to just preserve, given the depictions that we already have, and start off with just OCT. Do we want to show that initial run? We did have the catheter down up front, and could not get any imaging. So we did have to take a 2.5 semi-compliant balloon in order to get enough flow to actually do the OCT. So let's take a look at the OCT and see what we need to do. There's a couple different pieces that are going to be important. There's a lesion just proximal to the bifurcation. that we need to assess, as you can see there. And then obviously, what do we need to do to the calcium that's relatively severe there in the proximal bit?
So you want to walk us through this, John?
Okay, so perhaps if you could just pause there, just scroll backwards for me, just come back to about go to 10, so beyond this lesion. So if you can just now go more proximal and find a zone you want to land in. I would avoid that distal segment. Here it looks great landing zone there. So if you press D on your tableside controller if you have one, but just give us an external elastic lamina measurement there.
3.5.
It's going to be bigger.
No, that's
Out a little bit farther for us. Keep going. In a bit.
Yeah.
And bring the bottom one up a bit.
Yeah.
Lovely.
Okay.
That makes sense for a right coronary.
Yeah. Okay. So what have we got? Sorry, I can't. 3.5. Okay. Now, so start to come proximally. So that's a safe landing zone for you. Okay. So fibroatheromatous plaque, and we're just starting to see a little bit of calcium coming in there. And if you can just roll back now to around 22. So we're seeing between sort of 6:30 and 5:30, you've got a little bit of calcium nodule coming in there. And there's something also coming in around 3 o'clock. So just drag it through the lesion. So this is as the calcium is building up. More calcium here. You've obviously got some disruption of the endothelium. We're getting some more, still nodular there, more eccentric here, coming round the vessel. Keep going. And we're now seeing a more concentric distribution. Okay, so just stop at this point. If you just bring in either side, if you wouldn't mind just bringing in the blue markers either side, just on the longitudinal view. So the middle panel.
Go down.
On the longitudinal.
Middle panel.
Yeah, I just want to get
up to the right.
I just want to get the MSA of that segment. Bring that in.
There you go.
And yeah, we can get the MSA on there. Okay. Well, what we're seeing here.
2.55.
Yeah, 2.55. So this is the segment which has still got a lot of unmodified calcium. There is some disruption in the calcium continuity. If you see at 9 o'clock, I think that may be an initial fracture. But still a very heavy burden of calcium. And I think we can't quite see the depth of the calcium in between around 9 and 2 o'clock. Maybe you could see if we can get a calcium thickness measurement there. Just
scroll up. Scroll along a bit further.
Just on the axial view.
That's it. Scroll along, you see some nice thickness coming up.
Yeah, there's the eccentric calcium.
Yeah.
Keep going.
Okay, we're now sort of heading out of the calcified lesion here. This is more just fibroatheroma. And then the proximal vessel, where are you going to land? Around there is fine. So just set that as your proximal point.
Grab the little blue line.
Yeah, so you've got 26.6 between the lines. You've got 3.5 distally, so 38 rather.
Good.
So it's going to be a 3. Actually, move your distal end in, please. Your distal end.
Yeah.
Keep coming.
Yeah, keep coming, keep coming, keep coming, keep coming.
Go to the bookmark. There you go.
There we are.
Oh,
No, the bookmark's in.
Makes much more sense.
Too much.
Yeah.
Back out a bit.
Probably just gonna be 20.
Go to the bookmark. Just go to the bookmark.
Yep, scroll out
Just scroll out. Just drag
Well
it to
done.
that point. Come in.
to like 13 now. Lovely.
There it
32,
is.
32.
32.
Perfect.
Okay. So that's
Great.
that readout there would be a 3.532, and you'll
that's the diameter though, John. I think the vessel is larger. Can you just hover over the white line for a second? On the cross section, right? It's 4.70.
Yeah, so it's probably going to take a 4 there, isn't it? So I think we've got some work to do within the lesion here. So I would say I would take a 4 millimeter shockwave balloon here. So based on that distal external elastic lamina, you take a 4. And I would give all of the shocks within that segment between your proximal and distal landing.
Perfect.
We haven't done the co-register yet.
Or
have we?
shall
I mean, you
Yeah,
can sort of
So
see here.
let's ask the panel in the meantime. So one of the questions that comes up consistently, Margaret, about eccentric calcification is, do you need any lesion modification? Clearly there's dissections already. We used a small balloon. What do you think the iterative advantage is of performing lesion modification in this case? And how do you know whether there's going to be a benefit? If you put your stent in, it's too late.
Yeah.
And if you've not done it, you could have a regret.
So I think the worst thing you can do in a case like this is end up with an underexpanded stent and a suboptimal MSA. So I think if you're in any way concerned that you've got a burden of calcium that's going to result in that, because we know that once your stent fails, it fails repeatedly. So we want to get the best result the first time round. Yeah. So particularly in this case, down in the middle of that lesion, there was a segment where we could really see there was thick, pretty much almost probably somewhere between eccentric and concentric calcium, but there's a big thick plate. See that still frame they've got there? We can see down there between 3 and 6 o'clock. So there's very thick calcium there. And I think the concern is if you don't modify that further, you're going to put a stent in, it's not going to expand towards the right-hand side of the vessel. It's just all going to push and hyper-expand on the left side of the vessel. You're going to end up with a D-shaped stent with a suboptimal MSA. So I think for this patient, do the right thing the first time to get a better long-term outcome.
Yeah.
So I'd be looking to modify that further and try and really impact on that deep, thick calcium on the right-hand side of the vessel.
Yeah, all the semi-compliance done is go towards the area of least resistance, right? So we do have some dissections, but again, to your point, not through the thick calcium, and we haven't done anything there. And so we're going to try and get some cracks in that area.
Yeah, I think the question we're really asking is what's the threshold of therapy for calcium-specific therapy? And logically, that depends on 2 factors. One is the thickness of the calcium. Is it brittle? You know, does it break easily with concentric force, if you like? And the second thing is the arc of the calcium as well as the length. I mean, we've done scoring systems, but we think about it mechanistically. If you have a very small arc of calcium, we can expand, say it's a 25% of the arc, so we can expand 3/4 of the vessel and get a good MSA. And the more that encroaches, the more we're relying on adventitial overstretch rather than modification of the calcium itself. So I think that's why you see people who don't modify calcium getting D-shaped stents, but sometimes reasonable areas, but you also run that gauntlet of safety. If you want to push that envelope, you're relying on the vessel stretching away from the calcium rather than concentrically.
So that's a great example. Just, Rob, you want to talk to us what's happening with your balloon here?
Yeah, absolutely. So can you see here? And you see what's happening with the wire, Ziad? Do you want to talk about that? You explained it so well.
Yeah, so basically when your wire is touching or abutting the calcium, basically that accentuates your eccentricity. So when you started before you, on your original inflation, what you could see is the wire biasing towards the calcified side. That basically would be what your stent looks like. Your stent strut would be in that shape. And so as you've started expanding, even at 4 atmospheres, what will happen is the wire will start to move more centrally, and that means you've started to fracture the calcium.
Yeah, I actually think that's one of the most important additions to imaging and management of coronary calcium, that particular point, which is free information, which actually advances in angiography have kind of brought to the forefront. But that observation is extremely important, and I think we don't really make the most of that.
Yeah.
There we go.
And one really important concept, and although this case is a largely eccentric case, rarely does any single type of morphology live in isolation, just like in the left main. It's usually that eccentric calcium is part of a plethora of different nodules, concentric. And what's important is that you modify anywhere there's calcium that's going to get metal on top of it. And so that eccentric lesions, you do want to use some pulses on that, maybe not all 80 if you've got a long lesion, but make sure that we're modifying and fracturing to prevent elastic recoil, to prevent the D-shaped stent, to improve symmetry.
It's another one of those important behavioral effects that was also noted on within the studies where you see we're drawn to these high-grade lesions and we underestimate the impact of moderate-grade lesions on MSA.
That is a critical point because in Prepare Calc and Rotaxis, the minimal stent area in both studies happened outside of the maximum calcified segment, which means that you go in with your atherectomy burr, you throw the kitchen sink at it, you dilate the heck out of that max calcified segment, then you put a 38 millimeter stent. And then the MSA is 2 millimeters from the proximal edge. And that's what we're trying to prevent here is that anywhere that gets metal gets shocked.
Simon, can I just ask about the numbers of shocks that you've delivered so far?
What do we have, 20 left?
Yeah, so we've got the C2 Plus, and we've delivered 70.
Yeah, okay.
And Robert's just working his way back, and we've concentrated most energy in that section that we saw in OCT.
What's really nice is that having the C2 Plus, having more shocks available. I mean, I don't have to worry about, what if I just get 20 here? Gosh, I really want to make sure I have it for that thick rind more proximally. It's really, really nice. And you can see Ziad, exactly what he was discussing with how the balloon is changing, how the wire interaction with the balloon and the vessel is changing. It's really, really nice.
Simon, if you want to show that, maybe if you do a stent boost and then show us the stent boost, you can really accentuate what that wire bias looks like.
Yeah, that's looking good. I think we might be good.
Stent boost, Joey. You could give her some morphine. Yep.
How many shocks have you got left? How many shocks left?
We've got
40 left.
30.
Why not give it all? Give all the shocks here.
We'll give it all. We'll give it our all today.
To the whole length.
They'll leave nothing on the table.
Nothing on the table.
As Jeff Moses says, there's no point taking shocks home.
No.
That's very true.
Well, you say that.
I mean, the great thing we've seen in this case is we've seen even with the IVL balloon, it's now fully expanded, so we're looking good. I was wondering if a question to the panel, is there any value now in differentiating between concentric and eccentric? Now that we've seen IVL work so effectively, do they, in their practice, have a different algorithm for concentric and eccentric, or just sort of all group it together?
I think that's a great question, Simon. My position has always been that concentric, ironically, is the easiest to manage in that you can see the problem early. It's quite see the problem early, and it really is one of force applications. So balloons are actually safer than concentric lesions because they either crack them or they don't crack them. If they don't crack them, then you can go on something that does crack them. In this case, depending on how tight the lesion is, whether that's IVL or rotor or some alternative therapy.
All right, go for it. We're going to be finishing up this IVL soon. Do you guys want to see an OCT before or after an NC?
Before, just to see the acute gain, yeah.
So if you've reached that threshold of therapy, then I don't know what the alternative with eccentric calcium is. I don't know what other calcium modification therapy you can use. Am I missing something, Margaret?
No, and I think the other important point is that for when you modify the calcium when it's concentric, it's much easier for the operator to know they've modified it.
Exactly.
Because you get these clear cracks. The problem with eccentric is often you use whatever therapy you've used and you're like, I'm not quite sure if I've modified it. And I think, so it's an easier thing to trip up on, I suppose, in the concentric situation.
Exactly. Exactly.
A really good point there, Margaret.
It's a little bit like the nodule as well, isn't it? Like often in imaging, you're not sure how much you've modified it. It's a similar type of problem.
Especially now that there's very strong data from two completely separate sources done in completely separate cohorts show that we miss the fractures on OCT 50% of the time. So we're only seeing half of them. And I remember when, John, you presented Disrupt CAD3 and showed that the expansion was the same with fractures and without. I'm like, that can't be true.
Yeah.
That doesn't make any biological sense.
Yeah.
No.
Now it makes sense.
Well, the
Because
explanation.
you can't see the fractures, it'll still work. It's just that it's at the optical limitation of OCT.
Yeah, it's just
And
the
also the angles.
microfracture.
Of course.
The blocks are held together by the
Yeah.
soft tissue, yeah.
And that's another important concept that's coming up, this concept of debonding,
Knowing you're
right?
ready.
So the back wall of your calcium's on fibrous tissue. As you expand it and break it, you've actually peeled it off
calibrate,
like a
click it.
scab.
Yeah.
So that improves compliance and compressibility.
Are you ready? Enable pullback. Okay. Okay, hit start. No. Okay, you got it.
Good
A
job.
bit premature.
It's going to happen.
Yeah.
I think it's be okay. Just if you could co-register it for us, please, if you wouldn't mind.
It's
Maybe go full
There you go.
screen.
It's a remarkably nice looking vessel, this.
I know, I was just thinking that as well. It's really woken up.
that's it.
Quite a proximal
Just hit play.
bifurcation.
I'm always slightly jealous when I see
That's
vessels
it. Well
like
done.
that.
I think on AptiView you go the other way.
You've gone the wrong way around.
Yeah,
Cancel.
wrong way around.
Co-register. Start at the bottom. Lovely. That's it. Yep. There you go. Continue.
So for the panel, let's say, okay, the data's out. I've just started imaging. Fine. I'm going to use it to help me get length, size, calcium. Do I really need to run another imaging run in between my calcium modification strategy and stent deployment? Can you guys speak to that a bit?
I think it was very helpful when we were trying to work out the mechanism. And I think when we started doing OCT, we started doing IVL, the very first cases were done with OCT. And I think it was actually instrumental in working out the mechanism.
Swirl with the guide being out.
I don't think it's essential now, if the balloon is expanded, to prove that you've got cracks. I think you'll have some form of calcium cracking, whether it's microfractures or macrofractures. If the balloon's expanded, I think that's imaging enough.
I'm not sure I agree with that. I think it's interesting because clearly imaging has limitations. It has limitations in the same way as angiography has limitations.
That's the right idea.
But it's part of the puzzle. And I think leaving it out is quite a big piece to leave out, particularly when you're managing a long section
Yeah.
of disease, which is heterogeneous, and
Yeah.
you may have missed a bit or
give us
what
a
have you.
correlation.
And I don't know what the cost pressure or the time pressure is there, because you've committed to imaging.
Yeah, that's,
A run
ACT?
takes you
I'll
5
get you an
minutes.
ACT though.
I'll get it.
I suppose
don't know.
the cost is contrast, but we're now routinely using saline for OCT.
But you do an angiogram anyway, though, wouldn't you, before you put a stent in? So
Yeah.
are you even getting contrast as a cost?
No, so I think you're absolutely right.
And also, particularly if you're on that journey with imaging, what you need is a lot of imaging.
As much information
A
as
lot of
possible.
imaging. You need
Yeah.
to see cases, you need to understand the differences, you need to get familiar with all the nuances. And I think it's just should be part of the flow.
You guys want to use the co-reg to show me where
I
to put
kind of
this
like
NC
the confidence it gives me, if I see it. And also, to be completely honest, I
just go
think
for it.
every case I image, you learn something. I feel like it makes you a better operator. The more you image, the more you look at what you're dealing with,
All right.
Yeah.
the better you become at managing the cases. So I kind of like it because I feel it gives me confidence to proceed with the case, knowing I'm going to get a good outcome, but also I feel it makes me better,
But you're also assessing vessel trauma too,
Yeah.
in a way that's not that easy to assess outside
whiz over
that
to
kind of
Ariel here?
landscape.
After
So,
this, with this
I mean, we
balloon
shouldn't be
shot?
kind of waving the flag. Imaging answers
Joey, whiz over
it's
to
answer the
Ariel.
world peace. I mean, it's not answer the world peace, but it's part of the puzzle.
What do you guys think?
Back to Leo.
Fully expanded, I think. Is there some eccentricity there? I can't see from here.
Look at that.
I think in
I'd
one
say,
view, eccentric, this view looks
A little
much-
bit.
That's the key of
Compressions.
needing to do
Slow
two
bit.
views to look at balloon, look at wire
Not a lot.
concentricity. It looks pretty good.
Yeah.
I mean, it looks very good.
Better than it was.
And
You could actually see that spot on the OCT when they came through, couldn't you?
Yeah.
It was
There you
very D-shaped lumen.
Yeah.
Just to get
Probably.
around that bend. There
It
you
may
go.
be that some of this
Lovely.
calcium is medial as well, so it maybe is less important in terms of whether you've modified medial wall
ACT in
calcium.
between,
Yeah.
I mean, what age is the patient again, Simon?
85.
86.
Yeah.
So it's pretty plausible that she's got
Case has been
some
going that long.
medial wall calcium.
Yeah, and that ties in with our kidney function as well.
Yeah.
What's the
All right,
renal
so
function today?
is everybody comfortable with us putting in the stent now?
Yeah, I think so.
I mean, if you wanted
Yeah?
to do a
All
run
right.
here, of course, in the right corner, you could use saline interchangeably with contrast. You don't need
So
to.
20 ml saline syringe with the guide properly in.
Good first time.
You can try.
There's been a request to potentially do a saline OT
Okay.
of CT.
Let's get the stent ready though, and we'll do the saline OCT run.
So anyway, go ahead and get the stent ready.
Eyes on the
Can you
prize,
go
Simon.
back? Yeah. What did we measure up the last time? It was 4038.
32.
432.
Okay. Could we get that stent?
I mean, that
to
is
about
one
33?
advantage, of course, to the
Giants.
imaging is
33,
that,
sure.
when you've now done high pressure dilations, you may have extended either had plaque prolapse or plaque
4032
protrude, and then you may end up needing a longer stent.
And can we get a fresh? Yeah, I'll just squish it up here actually. Take saline in here. There's a flush on this, would you, Joseph?
So take a bigger syringe, guys. We use either a 20 or 30 for your saline runs,
Okay.
just because it's less viscous.
Now, when you seat the guide, like you're okay, sure.
Just flush the small syringe
Yeah.
at the side. That's it.
There you go.
Yeah.
Auto calibrate for us.
Have you got somebody who's going to press the trigger?
Hold that, Joseph. Hold that there. Just so it doesn't trick down. Auto calibrate for us now. And get ready to go when I say. Okay, so hit enable, pull back. Start, pull back. There we go.
Well done.
You got some
Well
fractures
done.
now
Nice.
that you didn't have before.
Nice clearance.
Hold on just a sec.
Oh, what's happened?
Hey, get me a 4.0 semi-compliant now, please.
Oh,
Yeah.
Perfect.
burst, yeah.
Come on.
Yeah.
Let me have a 4.0 papyrus, please. Okay. And you might have a little chest.
4.0
fracture.
semi-compliant. That's it, Joseph. Give me that.
Quick.
Yeah.
There you go.
Got it.
Thank you. I got it.
Maybe I can grab you a guide
give me a
extension in the
pause?
meantime.
Yeah.
Can you give me a pause of the previous, please? I believe it was right
Yeah,
here.
that's
All
good.
right.
Yeah. So, just going to take it slowly. There we go.
Okay. And let me
Okay,
just
we're
do a
up
quick
now.
puff here. Is this
We need to
contrast?
change. Yeah.
Looks
contrast.
fine.
There you go, you got it.
Looks good, yeah.
Floor safe.
Okay, pressures are good.
Okay. All right. So in a 6 French system, probably gonna have to ping pong
You've got
because that's quite large.
Well, we've got 6 French compatible covered stents.
Oh, nice. Okay.
I think the papyrus will go down.
Yeah, papyrus will go
Yeah,
through a
alright.
6.
Yeah.
Yeah, but I think it'll deliver as well.
Yeah.
I think you might.
I don't think we'll need a guide extension.
Yeah, with a guide extension
no.
to
Yeah.
unsheath it.
I don't think we
No.
need one. I'll just go
The
down.
4.0 just ran down.
Yeah.
Can we see the last
get us
run
a-
there, Rob?
You just
Here's
play
a
it
photo
back again,
papyrus.
Rob, if you can.
Say it again.
Play the angio back. We didn't. see
Oh,
it
sorry, I
very
don't
well.
have that.
Capacity.
Can somebody play the angio, please?
Got the wire.
Good job. Nice and easy and smooth. Good job. All right, wire, please.
Yeah. got
What
the
they say, smooth
Okay,
is
where you
slow
go?
and slow.
Yeah.
Slow is smooth and smooth is fast.
Yeah. Rob's Zen-like.
Eh?
He's Zen-like.
That's
You
it.
been doing your yoga, Rob?
I've been doing a lot of things, for better, for worse. There we. Okay, sure. Be that way. Come on then. Come on. Okay.
Just look out the guide Zilla for us. Yeah. First of all, give us that 4-0 balloon
Yeah,
back.
it's a key thing here
Liquid will go in the 6, Simon.
is not to fight too long with the stent and not let it bleed for too
There you go.
long.
It's lovely. We
Oh,
don't need
well
it.
done.
Good.
Okay. Back it off.
Yep. Just trying to get the guide back. There we go. Let me see that. Actually, okay.
I think we're good.
I
now.
think we're good here.
Just take it.
Yeah.
Further on.
Yeah.
There you go. Good, good, good. I want the 4-5 ready, please. Good.
Let's take a bit.
Good.
Leave it
You're
up for a wee bit as well.
Yeah, it's up. 10.
Yep.
Yeah.
The biggest thing is these things often really
Stiff.
need a bit massaging
very
to
stiff.
get them
Yeah.
open. The good news is you see right. Oh, there we go. All right. Never mind.
I think it's in this section here. It's
It
bulged
is.
out.
And that's where I'm seeing the stent. You see it curl right, like?
Yeah, yeah.
That does mean there's apposition of the stent and therefore the PFTE on the site. I still think we're going to post-dilate before we check. You're okay. You're doing a good job. All right.
Okay.
Hold on just a sec. Yeah, we just have to be careful with LSD. There we go. All right.
So I think, I mean, the reason you and I were talking about using a guide extension, and Rob didn't like that idea, but these strip off more easily, in my opinion, than regular stents.
Yeah.
And so I think in this case it made sense because it's a very large artery, but there can be an advantage, of course.
The time efficiency as well.
Oh, 100% Z.
Yeah.
There's no question about that. You guys okay?
Going. Yeah,
Oh,
it's
you
going.
already got it. Nice. Good job. Yeah, give me a
And
little.
also, if you started,
Show us where you are, if you wouldn't mind. Just
Nice landing zone here.
There's a bit of plaque there at the
Oh.
edge, yeah?
yeah.
So we definitely need to get that edge. I think it was over 50%.
Yeah.
There we go.
Look at that.
There we go.
Look at
Well,
that.
there's no doubt about where the stent starts.
Yeah, Shockwave really
awesome.
prepared the way for the covered stent well.
That's right, Mark. We need
We'll light this one
Shockwave.
up.
So then we'll take, after this, it's the 4-0 back. Thanks.
Do you think that was there in the pre, or is
Why
this
do
a
you need
guide
the
induced?
40NC back?
for the front end of the stent of the
Have to put the 3-5?
But do you need an NC here?
I don't think you just
After
just
the
need
stent,
a
after the
compliant
stent.
balloon
or,
yeah.
or a
Sure, yeah.
stent.
or a stent balloon. Yeah.
Yeah.
Got where?
Ladies feeling happier now,
That's
Simon?
good.
Very nice.
Yeah, she's
Yeah.
happy now.
Can you give me a LA crane, please? There you go.
Can you bring up one of the road maps that we took
Just a
before?
bit more. Maybe a puff here.
Ready? High rads.
You ready?
Go high rads.
Okay. Just a bit in.
Yeah, a bit further.
Just a bit, though.
I think
And then I'm going to
cover
take the
this bit
guide
here,
in
Rob.
just a hair. Yep. I just want to make sure we get the ostium, though. All right. You ready?
Okay.
All right. All right. Good.
Not
Looks like
any
we're
further
just a
in than
millimeter
that,
out.
are we?
I don't know.
Maybe just a bit.
Don't advance, put that in, I don't
So
think.
look at that parallel, that tram lining on the right of the
It's
vessel.
really
Yeah.
incredible, isn't
Amazing.
it?
I've never seen that before.
Yeah, it just shows how big the artery is and how the
Straight up,
calcium got
double
pushed
check.
out.
Exactly.
That was the medial calcium. that
Maybe we can
pushed
also do
through.
a spider
Yeah.
if you guys want to see
Yeah.
it, but I'm pretty happy here. Is everybody okay at this?
Yeah, looks
Yeah,
good.
yeah, you're in charge, Rob.
Let's do it.
While they're loading this, do you guys, maybe they can show us the OCT. I'd just be interested to see if we can
See the perf.
see the perf and see what happened.
Yeah.
It's a great call, Z.
And, I make that full screen if you can for a second.
I got where? Thank you.
Okay, so let's see what we could see here.
All right.
Can we co-register it? Because then we could
Yeah.
Yeah.
find exactly
Should be
the
here.
point.
There it is. That we were.
Get it for you.
Possible to get a freshie.
There we go. A bit.
See if we can get it down there, yeah.
So there's quite a lot of
Right.
contrast in this Ceylon, isn't there?
Yeah, because it wasn't flushed. Actually, it's quite fortunate. That's how we saw it.
It's a new one. Oh, it's gone. It's gone. That's all we needed.
And that's the first
Right,
one,
so-
because if it hadn't been saline, we wouldn't have seen
Stay away
it.
from it.
Right.
That's what I'm doing.
Yeah, so
It crept forward a bit.
Yeah,
Okay,
Took
so
a breath in.
look,
There you go.
Very, very thick, very thick calcium. So you're
To
seeing
be honest, it was supposed to
than
be a
1
saline
millimeter.
run. That one
Yeah.
bit of accidental contrast. Thumbs up.
Yeah.
There?
All right.
there's the dissection.
Back.
Where that was the dissection flap that we were concerned about before, right there.
Joey, show us the OCT, would you, so?
If you go,
Okay.
if you go a bit further down, just drag
in there and
drag
mold it, or just see
the
what it looks like on the.
Where's the
Just
co-reg,
do you want to take
Jamie?
the 4 or 5 in?
Yeah, I don't
It won't co-reg with saline.
See on eyes.
Because
That's
the way the
contrast,
OCT
though.
works, it looks for
should
the
expand
area of
the DS,
interest
right?
as the
Because we have
contrast
a
fill
4
segment.
opposed to
but it was
4, 5.
contrast back.
So
Yeah,
we
it's
should just
contrast
do
though, isn't it?
But I wouldn't maybe go nuts.
Yeah,
there you go.
yeah, you're right.
Here it's
but-
here it's appeared now.
I don't even think it went up to 4 or 5 though. When we looked at our IVUS.
That's
run.
fine.
Seems to be disappearing.
Joy, bring us back up
Yeah,
there.
right
Bring us
there.
the IVUS up. would
There.
you?
Is that
There.
it?
That's your perforation.
Yeah.
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 Just go stop on the perf bit.
Ah, there we go. All right.
Where's your co-registration marker? Can you put that back on?
That looks like it should be the point, shouldn't it?
All right.
Yeah.
Go ahead.
That's the lens.
So
Go
is it
ahead.
the
That's
bottom?
a
It was a
transition.
bit more.
Yeah, there you go.
Good.
Yeah.
The lens will disappear as soon as it's not sure anymore.
Ah, okay.
That's the perf
There.
right there.
Yeah.
Here. You see on the top at about 12 o'clock,
Yeah.
it's gone through the media,
And 11, 12 o'clock up
through
there.
the adventitia. Yeah,
Yeah. And all the calcium's in the other surface.
yeah.
Yeah.
The other calcium is from 6 o'clock right the way through to probably 12.
Perfect.
Yes, it's perfed on the non-calcified
The
side of the vessel.
non-calcific side, yeah.
Yeah, which is the mechanism
Yeah.
with
Eccentric.
with an NC
bit more to
balloon
go.
at high pressure.
Yeah,
Yeah.
what I like to do is
Very interesting.
just go up right here. There you go.
That's a
And blow
great
the guide
picture,
off.
right
Yeah,
there.
there you go.
I mean, I guess the question we asked before we saw this was, is there any point in doing imaging
Go back to the engine,
before you put a
please.
stent in?
Yeah.
Does that help to answer it?
Yeah, but I think the most important question, is there any point in doing NC
balloon after you've got
expansion
fractures?
after we've got fractures and we've got full expansion of the shockwave balloon?
But of course, here we couldn't have got full fractures, otherwise that wouldn't have happened.
Oh, right. So in between the NC and the IVL alone, I mean, that's where the perf happened. That's where the fractures happened.
But I
right?
don't-
Or
did-
not the fractures, but the expansion of the
But
fractures.
did the fracture, did the perforation happen after the shockwave? No.
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 But it can't.
It happened
do,
after
of
the
course.
NC.
It did.
Yeah, but because there wasn't, at that point, there wasn't sufficient modification of the eccentric calcium.
Yeah.
Because
Yeah.
it can't happen otherwise.
But then if you,
Yeah,
if you
I think that's right.
If you avoid high pressure inflation and you don't
wanna
go
image again?
up over a certain size, because you wouldn't go over a 4 here, would you? So, but 4 millimeters NC balloon, its conformability, if the vessel had expanded at that point at low pressure, then it's done.
I guess the question is that, you know, having seen this and that we understood what's happened and all the rest of it, with that information, what would you have done differently?
Yeah.
That's an
Figure it
interesting question.
No NC.
And would that have been sufficient to get a good stent result?
Well, I think it would have been, because I
Ziad?
think the vessel had been sufficiently
Yeah, I think so.
modified to allow at least some.
I think Margaret put it
Expansion.
best. If you image in between and see the fractures, it really gives you a sense of security that stent's going to go, you're not going to have any problems. If you don't see the fracture, it doesn't mean that's not going to happen, but you still have a degree of uncertainty because you can't see half the fractures.
Yeah. So it may be that the answer is, if you're going to check with a balloon, don't go mental.
Yeah.
Yeah.
I suppose one
Nominal
thing I was
pressure.
thinking, it's a little bit about defining the acceptable result, is it not? You know, because those thick plates of calcium, very thick, over a millimeter, they're not going to disappear. We fractured them, but they're still there. And I'm wondering whether, on hindsight, taking the 4.0, when we put it up to 12, 14, there was still some wasting, and we pushed it up a bit higher than that. And I just thinking about, you know, what's the acceptable result here? 4.0 at 12, we've got good expansion in orthogonal views. It's not perfect, but
You see,
I just have
I think it's a goals of therapy question, because, you know, previously we'd used NC balloons to drive the result through force, concentric force. And we've now learned that you can't do that when there's eccentric resistance. So you can use a balloon after IVL to show that you've got sufficient space to implant the stent and sufficient restoration of compliance. But if you continue to that next stage to try and modify it, you're just not learning the lessons of what concentric force does.
Yeah, I think, Simon, you're right. I think probably the lesson is that maybe you take a 1-to-1 balloon to nominal pressure and check in 2 views, and if it looks you're going to get a decent MSA, then maybe that's where you back off. Maybe that's a lesson.
Yeah, or you go back and modify it further.
Yeah.
Well, James, your point earlier was, not for right this second, so sorry. The goal is, hey, I've taken my biggest IVL balloon. What exactly do you think else I'm going to, do here?
And we had a 4-row balloon that was well expanded. It wasn't perfect. So just what Margaret, James, and yourself said.
I think that's right.
That was the point to implant the stent.
I think that's right.
Didn't need to push it to 16.
Illustrative. All right. What do we think of our IVUS here?
Looks fantastic.
Really nice.
Very satisfactory.
Really good.
Very good.
Really good.
Edges, medial dissection, there aren't any, you nailed, the ostium 2 millimeters out. The expansion is fantastic. It's fully opposed. It's hard to argue.
Distal edge looks great.
It's about 1 millimeter out. Fine.
Don't make me measure it.
Don't
make them measure.
Forgot who I
Don't
was
worry,
doing.
you won't be coming back.
Shall we check?
Okay, I'll just bleed this back. Okay, we're good. I'll just check we're engaged.
Yeah.
Okay.
There we go. See, am I a little bit more coaxial here?
That looks great.
There you go. All right, you ready?
Yeah, ready.
Mm-hmm.
Oh,
Okay.
That's
that's what.
still bleeding.
A little bit there.
Okay.
Just a balloon inflation, though.
Yeah.
Give us the
Yeah.
photo back
ACT
again.
fall.
Yeah.
Maybe put a balloon up and just
Semi-compliant for
do an echo while you're
5-10
waiting.
minutes.
Yeah.
I think what's happened is the distal stent edge of the covered stent is in a sort of aneurysmal segment, so there's still
Malopposed.
it's malopposed, and so there's now that when you do injection, there's a way for blood to track to the path of least resistance and actually
And it
sneak
shows like a
around.
jet, but it's probably not flowing like a jet.
Oh, it's much smaller than it was for certain.
Yeah. And you probably improved flow as well by fixing the proximal end as well, haven't
Yeah.
you?
Yeah, of course.
I've thought about this as well. I mean, it would be interesting here to put the balloon up distal to the perf site and see whether it's flowing. If we go past the perforation site, put it up here, right past it, and see whether it's flow coming around the back of the stent or not.
You want to take a look?
This is going to stop.
Ready?
Yeah.
It's slowing down.
Yeah.
I would do another 5 minutes.
So would I. And the other thing, if we were, the other thing to think about, and this is the influence of having
Another thing
moved
might
to
be a
work in New
4-5
York,
NC.
is put a right heart cath in to guide your fluid resuscitation.
Yeah.
If you work because of our presentation
Can you?
with the heart.
This is a 4.0 balloon. What about a 4.5 balloon?
That's what
Well,
I
that's
was
what we were
asking.
kind of discussing. I
Just
do
use a
wonder. What do you guys think?
Yeah.
in the proximal
I
segment
mean,
first.
I think in the like John just said, in the proximal segment to seal any inflow.
Yeah.
I think that makes a lot of sense.
I mean, it's more or less 4 or 5 that vessel anyway.
Yeah, and you have your
we
IVUS, so
get
why
a
don't you
4,
measure
5,
your
20
lumen
NC?
area in the IVUS at the interface between the covered and the non-covered stent? That'll give you an idea of how big the lumen
Just
is.
measure your EL from the IVUS or from the OCT in that segment, the proximal
This
segment.
balloon just farther back.
So one of the worst things is when you have this event occur and you haven't had it gone through the entire vessel prep. That's
Yeah.
Oh,
that is.
I mean, delivering
just
your
Painful.
covered stent, extensions,
No, yeah.
it's a
I'll just leave that.
disaster.
Sorry about that. Yeah. Let me
That's
just.
when you need a ping pong guide.
There we go.
Okay, ready?
Yep.
Picture.
Looking better, I think.
Yeah.
Come on.
It's trying to
Yep,
stop. Oh,
slowing
it's
down.
almost there.
Yeah.
It's almost there.
Pretty much stopped there. I'd probably be happy with that.
ACT
think
falls a bit
so.
further, you'll be good.
I'd stop
Yeah,
there.
exactly.
Yeah.
Yeah.
I think I'm.
Simon's on
Full
call
protein
tonight,
one.
anyways. So
Yeah, I'm hearing what you're saying, Rob. I like that idea too.
Yeah, I don't think you need to do any more prolonged inflation.
Happy just to sit in here for 5 minutes, do you think?
Yeah.
I mean, you can certainly, why don't you give the protamine and you can use a diagnostic?
Well,
I just stop it. It's not
I
going
would
to get
just-
worse from there, is it?
I will just tell you, I do not like checking things with diagnostics because you already have a problem. And if there's something that needs to be done, then you're switching out. I don't know.
I mean, you can leave your guide and give the protamine. It's just, it's
2, 3, 2.
it's going to fly
Okay,
out.
so we got
if you take
the
your wire out.
ACT down to 230. We could
Okay,
spend
good.
another few minutes
I
doing
just
another,
stop.
another echo. Well, that's a bit more
I'd be
time.
done here. See you, bye. Just make sure Simon is on call.
Do you think you're cool?
Let's do an echo while we're here, just to check, and then we're done if it looks good.
Do you mind,
Navalia,
Navalia?
can you give us a hand? We've done one. We'll just check before we take the patient off the table.
Okay.
Yeah.
But Rob, fantastic demonstration of very controlled management of, an unexpected turn in the case. You guys were very cool
Well,
and
we've got a
walked
fantastic team here. Fantastic team, and unfortunately, not the first time this has happened.
through. The pressure certainly looks great now.
Yeah.
Yeah, it was the ischemia. All right,
Okay, ready?
push away from me just a bit. Just there you go. All right, perfect. You ready?
Yep. Oh, that's it.
Excellent.
Yes.
Just a small blush, and that's honestly going to be the crater.
Yeah.
That's going to be there.
Sort of
and
class
that's
one
okay.
now, isn't it? Just contained.
Mhm.
Okay, we'll
Yeah.
check again.
Good job. So the biggest thing with these perks, as you know, it's the 2-hour window. So we'll just make sure and get one about the 2-hour, like 75% perfs. If they got to come back, it's that 2-hour window, or 80% or something. Anyway, we'll just get another echo in about 2 hours. Cool. Good job, team.
Thanks, everyone.
Brilliant. Well, thanks, Rob and Simon. Great case, really fascinating case. That just about wraps it up for today. I hope you've come away with a better understanding of eccentric calcium, and thank you for taking the time joining us all here. As ever, all the classes and educational learning resources are available on the Shockwave Hub on the Wonder Medical site. Thank you.
From all of us,
Bye.
take care, guys.
Bye-bye.
Bye-bye.